Um, Good afternoon, everyone. So we come to the final symposium, not just for the day, but for the Sri Lanka Surgical Congress 2022. And we always keep, as we say, the best for the last. So this is it. This is a symposium on Hilar Cholangio carcinomas, and we've got a stellar cast today who are going to share between them their wide experience in the management of this, which is probably one of the most challenging problems hepatopancreatic biliary surgeon encounters. And I will now hand over to Professor Aloka Patirana to introduce the speakers this evening.
So we have 4 speakers today, and it's Dr. Jagannath, who is the Professor of Gastrointestinal Oncology at the Asian Institute of Oncology in Mumbai, India. Actually, I think you all know him because he has been visiting regularly and conducting several master classes with us in the recent past. And also, more importantly, he has helped us in the recent crisis where we requested donations from the International Hepatobiliary Organization to help us with equipment. So he was very helpful in that regard with us. Thank you, sir. And then we have Professor Krishnakumar Madhavan, who is a senior consultant of the Division of Hepatobiliary and Pancreatic Surgery at the National University Hospital in Singapore. And Mr. Hassan Malik, I think he has not joined yet, but he will soon join us. He is a consultant hepatopancreatic biliary surgeon from Aintree University Hospital in Liverpool, and he has a special interest in Hilar cholangiocarcinoma, and I was told it's also retroperitoneal tumors. Then we have our own Dr. Nilesh Fernandopulle, who is a consultant gastroenterologist and a senior lecturer of the university unit in Colombo. He's at the National Hospital of Sri Lanka. So I think you have organized as a case discussion. So
Aloka, can you hear me?
we can hear you, sir.
I'm so happy, I'm delighted, I'm thrilled to see you and Shiva there. I know the crisis you have gone through. I know the kind of resilience you have shown and the grit you have shown, and then we were very happy to help you. But to see you that you bounced back and holding this gives me a tremendous amount of happiness. And then Professor Madhavan, as the president of the APHPB, has been very, very supportive in helping you. So we are both delighted to be here. Next time we'll be there physically. That's a promise, 100%.
Thank you, sir.
We look forward to that. And again, let me re-emphasize as the representing the Sri Lanka Hepatopancreatic Biliary Association, the immense assistance rendered to us in the time of need through the Asia Pacific Hepatopancreatic Biliary Association, headed by Prof. Madhavan, and with all the efforts of Dr. Jagannath, and also the IHPBA to help our HPB units here. Thank you very much. So very briefly, how we plan to run this symposia over the next 45 minutes or so. We are going to present a couple of cases of Hilar cholangios that we encountered, and once we've done that, we'll talk about certain discussion points, and our speakers have a few slides which they will use to illustrate the points that come up during these cases. So what I'll do is I'll first run through the cases, talk about, or I'll illustrate the points that we'd like to discuss, and then we will go on to our speakers and talk about them individually. So let me start. So our first patient was a 69-year-old female, hypertensive, diabetic, presented with just transient jaundice. So that was the interesting part. Her jaundice was transient, associated with some constitutional symptoms, and imaging showed a Hilar stricture which was suggestive of a cholangio. But interestingly, though the initial bilirubins were high, all subsequent bilirubins turned out to be normal, though the alk-phos and gamma GTs were high. She had in another center been referred and had a episode of, or one cycle of chemotherapy had been given before she was referred to us. And on imaging, again CT, as you could see, shows dilated ducts. The arteries and the veins were intact, and there was no evidence of metastatic disease. This is the MRCP that you can see here. A focal stricture at the confluence. There were two right ducts and the left duct were there as a trifurcation or converging. That was the MRCP image. Now, the challenges or the questions that we had is, what do you do when you have somebody with just transient and normal bilirubins thereafter, with raised ALPs and gamma GTs? We've got a diagnostic dilemma. Is this malignancy? How do we proceed further in terms of imaging? What is the utility of getting brush biopsies or choledocoscopy? Do we do a right or left hepatectomy here? And how do we assess the adequacy of the future liver remnant and the role of portal vein embolization and ALPS? So these are some of the things that we would like to discuss in the context of this case. We will come back to this. And what we did is a staging laparoscopy, which was normal. We did a portal vein embolization. Unfortunately, we couldn't get segment 4 embolized, so that didn't work out. But post-embolization, this was what we found. We had a good segment 2, 3, and also some hypertrophy of segment 4. And we proceeded with extended right hepatectomy, caudate lobectomy, resection, and a left hepatico-jejg, following which she had a bit of transient liver dysfunction with a bit of ascites, but with a combination of diuretics and albumin, she recovered and was discharged a little over 2 weeks later. Fortunately for her, her histology was good. However, the oncologist decided to give some adjuvant chemo. I'm not sure about the suitability of that. And 1 year on, she is well. So that's our first case. And I'll move on to the second case. We can always come back and refer, which is a 69-year-old male with jaundice again, ASA1, good activity levels, typical direct bilirubinemia. Here there was, on imaging, you could see that the tumor had invaded the right portal vein. The left vein and artery were free. And there was, obviously, you could see right lobe atrophy with hypertrophy of the contralateral lobe. MRCP showed a hilar stricture, or the proximal common hepatic duct, with no involvement of second order ducts. So the question here was, decisions on how you decide on resectability here, the role and route of preoperative biliary drainage, if any, and also maybe touch on some technical aspects, the so-called no-touch technique, whether we would routinely do a portal vein resection and anastomosis, and the role of caudate lobe resections in this patient. Anyway, we went ahead with an extended right bile duct resection. We resected a segment of portal vein and anastomose and did a left hepatico-jejg. Incidentally, we had to do a right adrenal because there was a suspicious area in the right adrenal as well. He had a bit of a stormy post-op period, was there with us for more than a month, complicated by pneumonia, post-hepatectomy, liver dysfunction, and NCEF. It took some time for him to recover from this and get home. Unfortunately, his right portal vein margin turned out to be positive, much to our surprise, really. And it turned out to be a R1 resection. And we, looking back, whether we should have done a frozen section on the portal vein, and what strategies we could have adopted to minimize post-hepatectomy liver dysfunction. We didn't drain this patient preoperatively. I don't know whether that was a good decision or not. So Uh, welcome, Mr. Malik. I'm glad to see you joined us. So we've just looked at two patients. Uh, Dr. Jagannath, shall I hand over to you to just highlight some of the issues that we have in the management of perihilar cholangio carcinoma, and then tell us what your thoughts are in how we may have or how you would have alternatively managed any of these two patients.
I think let's focus on these two cases first, because you have presented them very well. Now, when we come to the first case, well managed. Now, there are two important questions in the first case. One is, why was the jaundice transient and it came down on its own even before the drainage? And you have raised a very pertinent question that should we be looking for something which mimics a hilar tumor, but it's not actually a hilar tumor. And in this particular case, I would just get a IgG4 done to make sure that we are not dealing with something which is related to that, and because the mass lesion was not typical. Of course, there is no doubt that before any diagnosis, that cycle of chemotherapy was just an aberration. I would strongly say that we would not give chemotherapy preoperatively. And even post-op, I would say that if nodes are negative and your margins are all clear, limited role for adjuvant chemo. There's one more question which you put up in your own slide, which is about segment 4 embolization. I would agree with the preoperative drainage plan. If you can get those questions back, some of the things is that is drainage necessary? I would say that yes, when you do a hepatectomy, drainage is necessary. And that's what has possibly happened in the second case. When you did the same procedure, you did the same extended right hepatectomy, this time without drainage. And that's the reason why he went into problems of hepatic dysfunction and just about made it. So that's the lesson which we always say, that hepatectomy would be necessary when you have this type 3 lesions. And if there's hepatectomy, then you would do a drainage, you would do an augmentation of the volume. Both are well in order.
Prof. Madhavan, in fact, in the first case, we didn't have to do a drainage because the bilirubins were normal. At the end of the day, the bilirubins were normal. It was just very high gamma GTs and ALPs. As for IgG4, it's quite expensive here, and so it was only available. The availability is a problem, so we couldn't get it done. But that was something we thought we should have, if we could have done it, but we didn't do it.
Yeah, if you see this question, Siva, is drainage always necessary? We are moving away from drainage for all cases. Say, for example, now you flip it. If it is a shrunken left lobe, even with a jaundice, and you're planning a left hepatectomy, perhaps drainage would not be necessary for even 6, 7, or 8 mg of bilirubin. But if you're doing extended right hepatectomy, where the volume of the left lateral segment is less, that's when you would err on embolization and allow the liver to grow. So that's how we would approach that. Unfortunately, the investigations for these patients are more than one. You need an MRCP for the ductal anatomy. You need possibly a triphasic CT for the vascular anatomy. And these patients do need investigation. So, and in all this, the thing, IgG4, if it is indicated, it would be worth it. Otherwise, it's not a routine investigation. So that is my call on that. Which drainage is something I would ask Dr. Nilesh to highlight on the ERCP pros and cons on the ERCP versus PTBD discussion.
Nilesh, would you like to...
Shiva, can you hear me?
Sorry.
Yeah. Can you hear me? There was a...
Yeah, we can hear you.
Okay, thanks. I'll just wait for...
Nilesh, you go ahead. After that, we'll get Prof. Madhavan on.
We can talk to... You want me to?
Yeah, go ahead.
So the place of, from an endoscopic point of view, in hilar cholangiocarcinomas, these patients have been definitely on a curative intent, but you get some patients who probably do it on a palliative intent also, and the drainage depends on. So the two options from the clinic's point of view, there is get the endoscopic approach, and also endoscopy can do the ERCP and the endoscopic ultrasound, and you get PTBD. The problems with ERCP is the cholangitis, because when we inject dye from the bottom, there is no control to where the dye actually goes into the liver. And the problem is, if you don't drain segments which have dye, there is a high risk of developing cholangitis, which obviously, if you're doing something with a curative intent, it becomes problematic for the patient. Patients will deteriorate also. So generally, the guide is, if any patient with like a wide bismuth classification, there's an endoscopic approach probably is a bit better. But if any bismuth 3 and 4, probably PTBD would be a better option for drainage successfully, and also to prevent the risk of cholangitis. It's basically like a simple.
Siva, can we have the MRCP image of this one, the first patient?
Oh, sorry, that's the, yeah.
So the confluence here is intact, isn't it?
Just at the confluence, yeah.
Below the confluence. Tumor is below the confluence, or?
Just at the origin, yeah. You got the 3 joining at that point. Prof. Madhavan, any thoughts on this?
Yeah. Thanks, Shiva. Initially there was some problem with, but I'm audible, right?
Yes, you are, very much so.
Okay, thank you. In fact, first of all, thank you very much. I just echo Professor Jagannath's sentiments, and we wish we were there physically. But that will be the next time. And then, of course, we will see you in most all Asia-Pacific meetings going forward. So anyway, coming specifically to this, the comments you were asking me, pretty much, I think Professor Jagannath has covered everything. 1 or 2 points. Again, from my brief experience in India, you can get hilar blocks from, correct me if I'm wrong, because I've been away for many years, but sarcoidosis, tuberculosis, these sort of, the diagnostic accuracy is one thing, which I will cover in some slides at the end, if you give me time.
Yes.
I had sent you a few slides, so
we'll run those later. Yes.
I think, I totally agree that even more than liver transplants, hilar cholangio is, I would say, if there is a level 5 operation in hepatobiliary surgery, that is really hilar cholangiocarcinoma. And the decision making but again, I will cover it later on. Giving a chemotherapy, was it given without histological diagnosis?
In the Sri Lankan context, we don't have tertiary centers that sort of really manage hepatobiliary cancers. And you do occasionally have, as I think Dr. Jagannath aptly described, aberrations in terms of how decision making is made. So I just highlighted that, but because we were wondering, this transient jaundice thing kind of foxed us a bit, actually. Why the bilirubin went up and came down, and this seemed to occur.
I just wonder whether, I wonder whether there was some sludge or something like that.
Exactly.
And then it passed, and associated some benign biliary issue. That's the only way I can explain it. But again, as Professor Jagannath said, I think if the patient is not jaundiced, whether you drain or not will depend on what's your plan. Is there a surgical plan, and is a surgical plan curative? Because technically nowadays we don't do surgery for palliation, right? There is very effective palliation endoscopically. So those are some additional points I just wanted to add to that case. But you've done a great job, especially with that first case. The way the second case went is normally, in my experience, they do go through, because you remove a lot of liver, and they do go through transient liver dysfunction. And the only other additional comment is that I have had a couple of patients who have gone home well after this operation, but they have had a second hit in the form of a cellulitis of the leg or something like that. And they ended up back in the hospital a month later with liver failure. So if you do an extended ride, and I think all of you are aware of Professor Nair's initial data, every case, and again, we can discuss this. And I'm delighted to see my old friend Hassan Malik there. Hi, Hassan. I'm sure he has some contributions, additional contributions to make as well. So I'll stop my comments there for the moment. I can answer any specific questions if you have.
Okay, we'll come back to you, Prof.
We have time. Yeah, thanks.
So I think in retrospect, even when we opened, we thought that liver looked, in addition to the cholestasis, it did look a bit like there may have been, the edges were a bit rounded. So probably the decision not to drain there was not ideal. Mr. Malik, what are your thoughts? Would you, in terms of technically, would you routinely go for a caudate lobectomy and lymphadenectomy? Would you do frozen sections? We got caught out on the frozen section, and we got caught out where we didn't expect to get caught out. That was the portal vein was positive. Would you routinely do it? And do you think, would you routinely do portal vein resections and anastomosis for Hilars?
Okay, thank you. And I do apologize. I was trying to dial in with Google. It wasn't working. Someone Zoom,
no.
I think.
No problem.
I've missed part of the cases, so I do apologize.
I can come back to that.
No, it's okay. It's fine. It's fine. So the key thing I learned in Leeds when I worked with a team there many years ago after leaving Edinburgh and working with KK was a very basic thing. With cholangiocarcinoma surgery, Hilar cholangiocarcinoma surgery, there are two aims. Remove all the tumour and don't kill the patient. That's basically it. So in order to not kill the patient, you need to leave sufficient feature remnant liver volume. You need to manage the jaundice effectively. In Liverpool, certainly we use ERCP more than PTC. There was the Dutch drainage trial, which was stopped early because of the increased morbidity and mortality in the PTC arm. In fact, in Liverpool, we use metal stents because the plastic stents will often fail before you take the patient to the resection. And we're able to safely resect these tumours with metal stents. And that's that's probably quite controversial, but it's something that we're working with our Dutch colleagues to write up. So the key thing is to have a healthy, ideally non-jaundiced patient with a sufficient feature remnant liver volume. The series from the AMC and Sloan Kettering implied that if you've got a feature remnant liver volume of more than 50%, very few of those patients die. So that might be a group of patients in whom you can get away without drainage. In terms of the surgery, yes, caudate is removed all the time. You need to resect that to get a negative margin. Yes, we do the lymphadenectomy. I used to many years ago do what Peter Lodge does and do the para-aortic lymphadenectomy. It just adds to the morbidity, with little gain. So our lymphadenectomy will go down along the hepatic artery, the common hepatic artery, to the origin of the splenic artery, and we won't go beyond that. If we find clearly malignant nodes around the celiac axis, we'll do a frozen section of those, and then if that's positive, then I think that's advanced disease. We do frozen sections intraoperatively of the duct, the proximal duct and the distal duct. Now, going to the issue of the margin, you're beating yourselves up, The reality is there are different margins in this. We published a thing in the Annals of Surgical Oncology a few years ago, a small paper on margins. And I think realistically, I would describe it as there are two margins. There's a true margin, which is what I would describe as a surgical or a longitudinal margin, which is the distal duct, the proximal duct, and the parenchymal transection in the liver. And then there is what the pathologist will often pick up as a circumferential margin, which I think is what you've got here, which I don't think is a true margin because you resected that portal vein. Okay?
Yeah.
So that's been removed. So that's not a true surgical margin. And that's probably a reflection of the biology of the tumor as it extends laterally, circumferentially, rather than a true failure of surgery. So don't beat yourself up too much. In terms of multimodal treatments, obviously we give adjuvant chemotherapy. That is on the back of BILCAP and the ACTICA trial, which is comparing cisgem to capecitabine, I believe has just concluded or will conclude soon. And that will give us perhaps a new standard. The controversy, if there is one, is the role of neoadjuvant therapy, which is increasingly used in a lot of other GI cancers. I'm not as anxious about it as others may be, but I think it needs to be explored in the remit of a clinical trial rather than as standard of care. But you may occasionally find a patient that you thought was inoperable, you give them palliative chemotherapy or chemotherapy with palliative intent, and they have a response, and then you may take them to surgery thereafter. But certainly, systemic chemotherapy in the neoadjuvant setting, I think, should be explored. We know from our own data and international series that if you've got node-positive disease, then the prognosis from that is exceptionally poor, in spite of surgery, in spite of adjuvant chemotherapy. And perhaps a neoadjuvant approach would allow patient selection. The other thing in terms of staging, I don't know if it was covered, is we're increasingly using PET scans as part of the staging for cholangiocarcinoma. And this was in the back of a really nice review that Wan Valley from the Christie was involved in.
We've got a slide of one of your slides about the decision-making chondria, Mr. Malik.
Yes,
would you like to just...
Yes, please share that. I mean, so we're involved with the International Hilar Cholangiocarcinoma Collaborative, and this was really set up from the AMC and Thomas van Gillick's group. And this is now, we have about 2,000 cases on that, but this was a series of about 1,700 resections. And the difficulty is this, that in about 16% of patients, the surgery was clearly futile. They died very soon after the operation. And this is mainly patients who are frail, elderly, who had an extended hepatectomy, who had a vascular resection, etc. I'm not saying that each of those in isolation is a contraindication to surgery, but it makes you question the opportunity of surgery. And then there's a group in whom they clearly do very well, okay? And that's probably the early tumours, the node-negative tumours in a younger, fitter population. But there's a big group, the vast majority, about 60%, is in this series where you really have to have a very difficult conversation and decision with the patient, with the family, within the tumour board and outside the tumour board. Because, you know, with this operation, you're talking about our median length of stay in hospital is probably about 10, 11 days. All our cholangiocarcinomas are managed within an enhanced recovery program. Our median length of stay for open hepatectomy is about 5 days. Our mortality is around 10, 11%, and that's the nature of this surgery. Unfortunately, our median age of patient is 70. They often have multiple comorbidities. And so you have to think carefully about that decision. And so that is always a challenge of this operation and the reality that you face. You know, we all remember anecdotally our last few patients, oh yes, they did well. But when you see this type of data, it does make you reflect upon the difficulty of this decision.
Thank you. I have a few slides. Prof. Madhavan, would you like to just let me run through these? I think it gives a very nice...
Yeah, I mean, thanks. Firstly, just additional comments to what Hassan said about the resection margins and frozen section. I mean, it depends. I was a proponent at some point of what is called the Taj Mahal resection, whereby you try and improve the amount of liver remnant you are leaving behind, rather than all the time doing an extended right and removing the caudate and segment 4. Now, in your second case, it had already, the portal vein had already decided the right side is gone, the left side had hypertrophied. So to some extent, that has been taken care of. But my belief is that if you are doing radical surgery with an intention to cure, which is the only way we do it now, then you go maximum. You decide whether, depending on if it's a bismuth 1 or 2, whether you just want to do a Taj Mahal resection. It will still give you the same clearance because, the additional spread is along the periductal margin and perineural. If you look at perineural and perivascular invasion, whether it's reported or not, it is 100% in hilar cholangios. That is the way it spreads, right? So even if you have a clear duct margin as such, or portal vein margin as such, the periductal nerves probably carry cancer cells. So this is a systemic disease. Okay, we managed to cure some people. So that is the first point. So what I put together, and I have, you see, for me, I had an issue with whoever encounters this patient in whichever hospital does something, right? And if it is an endoscopist, he puts a stent inside because the patient is jaundiced. Now, I went around Scotland for many years talking to gastroenterologists about, these patients. So I have a couple of slides, and I hope I don't take too much time. So these are the known factors. Only a minority of patients are resectable for cure, okay? And the nature of cholangiocarcinoma is such, it's unlike pancreatic head cancer or liver cancer, which is not resectable, the rate of growth is slow, and patients can have a reasonable period of palliation. But again, the R0 resection is the only chance of cure. Now, I don't think we'll discuss transplant at the moment. R1 resection may provide valuable palliation, where the other point is about skip lesions. I think there is very good data from autopsy series that almost all of them, we think we have cleared, but there are dysplastic changes beyond in the intrahepatic ducts. Next slide, please. Okay, this was the time when I was quite keen on surgical bypass, and Hassan might remember, maybe we did some segment 3 bypasses in my time there. But the point is that if you can get effective biliary drainage, that is one thing that contributes to effective and long-term palliation. As Hassan said just now, all surgical options are associated, generally 10% to 15% mortality rate and morbidity. Non-surgical options are now very good. Whether you do ERCP or PTC, I think it's debatable. Next slide, please. So what is not very well known is more and more patients are being rendered safely resectable. HPB units are developing. They are becoming aware. Patients are being discussed in what is called tumor boards. So there is no knee-jerk response whereby as soon as a patient comes to you, if you're a gastroenterologist, a patient is jaundiced, just do an ERCP. And nowadays, MRCP, of course, prevents those diagnostic ERCPs. Again, very important to differentiate. If you remember the first series that came from Sloan Kettering about segment 3 bypasses, vast majority of them, I think, were done for gallbladder cancer. So the results of that particular operation was horrendous, because gallbladder cancer, if you do a segment 3 bypass, you're just unnecessarily putting the patient through a major surgery for no effective palliation. Now, what we don't appreciate is inappropriate and untimely interventions can render an otherwise operable. Already our colleague physician said that if you inject dye into the bile duct, and it goes into the side you're going to preserve, and it goes into the side you're going to take away. If you resect, it's all right. But if you don't resect, or if you do a bypass on the left side, then the right side with the dye is going to be septic. It's going to cause problems to this patient. Next. Yeah. So I think this has been covered already. Effective palliation in those patients we cannot resect. That's what we have to strategize. I think a couple of more slides here, if there is time. I think the last two are the important ones. So this has been already said. There is no point really doing R2 and R1 resections, but just like Whipple's, most of them turn out to be palliative. That we can't help it. Next one. So these are, as I consider it, these are some of the secrets of successful outcome in surgery for hilar cholangio or no surgery. Appropriate selection of patients, accurate diagnosis, accurate staging, and of course we were quite keen on laparoscopic ultrasound and various other things, but that's not, it's not very widely used. We have published a few things, but I think if you're an enthusiast, then you can do that. Optimization has already been covered, portal vein embolization, drainage, the selection of the best surgical option. So, the more liver you remove, the more morbidity you're going to add on, and the best post-operative care. Next patient, next one. So the way I look at it is, to anybody, if you have an obstructive jaundice patient, an ultrasound, which can be done in any hospital now, shows there is a collapsed gallbladder, but in dilated intrahepatic ducts. They should by default diagnose hilar cholangiocarcinoma. And this patient should be discussed in a forum where there is a surgeon who has experience in dealing with hilar cholangiocarcinoma, and no intervention should be done unless the patient is cholangitic. I think if the patient is cholangitic, a PTC, PTBD is probably better than ERCP. And of course, you should have a good quality CT or MRI as described by Professor Jagannath. Next. Yeah, so we have covered that. Next. So I think wrong and delayed diagnosis, inappropriate early mismanagement, as I call it, can render the patient inoperable subsequently. Now, of course, there is adjuvant therapy and neoadjuvant, and then, as Hassan said, some patients do become resectable. Resectional surgery is very major. And pre-op optimization, again, we haven't gone into detail of that, or portal vein. If you embolize one side, should you drain that side if it's coming out anyway? So there are details to this. So somebody should understand this disease and then decide what is the best way to go forward. I think there is a last slide there. Next. Okay, I think we said that already. Is there one more?
That's it, yes.
Okay, so I would just stop that. It's more philosophical, and it's sometimes, trying to say this is the ideal or the gold standard, which nobody disagrees. But the practice is what you have actually seen. Somebody intervenes, and then you get the patient. But you need to add this into your algorithm, that this patient has got dye in the right duct. So is your original plan still valuable, or do you need to change your plans? I would stop there. Thank you very much for giving me that time.
Thank you very much, Prof. KK. I think that put in a nutshell, all the key principles and, as you said, philosophies around managing hilar cholangios. Just very briefly before we go on to the audience, very often we encounter patients who are deeply jaundiced, and you have to say do a bigger resection, so a right-sided resection. So you need two things. One is drainage, and the other one is the portal vein embolization. So would you do the portal vein embolization sort of after getting adequate drainage, or is there any? How would you time the two? I just like to know what you think of. Dr. Jagannath, how would you? Do you get your EBDs in and then let the bilirubins come down before you do the portal vein embolization? Does it affect how quickly the hypertrophy occurs?
First drainage, and I think KK has made a very important point. No intervention before complete diagnosis. When I say complete diagnosis, it's a complete imaging, and hilar cholangio, what I've learned from Eugene Nimura, it's a surgical plan. And I fully agree with KK, it's more complex than liver transplantation. Your surgical plan has to be ready before any kind of an intervention. So it's a planned approach, stepwise. Drainage first. and drainage first, allow the bilirubin to reduce. Hassan, we don't, in fact, when I showed my metal stent dissections like you did to UG was aghast. He said that, how did you guys do it? Because there's so much of fibrosis. And one of the very important things is that you lose out on the field of the duct. And Shiva, we have stopped doing frozen sections, believe me. Because, you have to be, grossly the surgeon has to be free. And one important thing you have to, how much you have done a right extended hepatectomy, you have gone to the left duct, you are now going to anastomo segment 2 and 3. Now, okay, your margin is positive. What are you going to do? So I think you need to plan it out and then stop it. Stop frozen sections. And your portal vein, I never send portal vein for frozen section, literally. Because this is all perivascular spread. It is not an involvement of the vein. The things which we do is drain first, allow jaundice to settle down, and then do the volumetry, and after that you do a staging. Now we are also trying to move from earlier on laparoscopy, which can pick up a few things, to a PET scan, which will give me the nodal staging, which is better. And also these patients do have a mental spread. Just last week we had a patient, we do a PTVD, we drain, and let me tell you that the MRCPs can be misleading. Like in first case, there can be overcrowding of ducts with an overlap. You'll mistake it for a type 1 disease where it can be actually a split hilum. So very important for us to drain and wait and do maybe repeat cholangio and then check it out. Second, do a PET scan or mental seedling or anything like that. You know that you're dealing with a different stage of the disease completely. Drain, after drainage, then portal vein embolization of the lobe, of course, which you're going to resect. Segment 4 is a little tricky, and I have always hesitated, having burnt our fingers, because if the intervention radiologist is not careful, the thrombus can spread onto the left portal vein, and then you are done. So I'm quite happy to allow only the right portal embolization and wait and see how the volume grows. And the volume, like in your case, a significant growth, which is perfect. So that's how, and this is one thing which KK has mentioned is there's a natural portal embolization in the second case.
Yeah.
And the volume has gone up.
Yeah.
Now, in that case, if you do a volumetry and you find that the left lobe is still not adequate, that means that inherently the liver is not a good liver.
Yeah.
So absence of hypertrophy after embolization gives you an indicator that you are dealing with not a good liver or a patient, and you have to be extremely careful in your volume assessment and not take risks in these patients. So you see, now NASH is so common that some of these livers don't grow the way you want them to grow. So that's that. And just a caution on bill cap is done on a basket of biliary tumors. So one has to be careful to extrapolate for everything. But we restrict any adjuvant only to the node positive disease and not otherwise. The first case was node negative and T2, so that is clearly out of adjuvant, this one. And the distal margins are also there. What is the step which KK is saying that this is beyond this, there is no return. This is the lower bile duct ligation and transection. Till then, you can do all kinds of movements around and dissect out. The moment you say that, okay, I'm going to go ahead and dissect, which is the preoperative, not always intraoperative, but you can find something. Then you ligate and cut the bile duct and lift it up and clear it from the portal vein. And that's when, yes, you have done it. So there is no looking back. Segmentary bypass is part of the history that now we don't have to revisit it again. That's it.
I just personally somehow feel happy after listening to all of you. I don't feel that bad. So the same sense you have when you are going to put that tie on the distal bile duct, you know that you've reached the point of no return. And that's a good point about not the futility of probably doing frozen sections, because once you've gone up to the left duct, what more can you probably do, I guess.
There are only two procedures. There are only two procedures. If you really look back and see, one is a left hepatectomy with cardiac lobectomy. Straightforward, left portal vein is involved, and then you go ahead. The second one is a right extended hepatectomy, because the right artery is the one which is closest to the hilar tumor. The left hepatic goes up mostly outside and then goes into the hilum. and the left duct is much larger, left portal vein is much longer. That's why Nyhaus can do the anastomosis. Has he done a no-touch technique on the other side? He didn't do it because it's a left portal vein. So that's also part of history. So now let's not revisit no-touch technique also. Okay. So the focus is the one thing is the right hepatic artery. This is the fellow who can give you trouble. And if he is not addressed properly, then you will be in trouble, particularly when you are planning a kind of a left-sided resection. And then suddenly you find that, oh, the right hepatic artery is going through the tumor. So in a CT angio, look at the right hepatic artery. In an MRCP, look at the ductal extension. And by and large, if it is showing that the second level bifurcation is also split, it is likely that there is a longitudinal spread of the tumor. So you have to determine the right-sided resection versus left-sided resection right in the beginning and based on the ducts and the arterial system.
Thank you. I'd like to open the questions out to the audience. We've had a tremendous discussion, but I'm sure you...
Sorry, Shiva, I think Hassan had his hands up.
Oh, yes,
earlier,
please do, Mr. Malik.
I mean, it's more of a comment. What this shows you is the complexity of managing hilar cholangiocarcinoma and really the need for this to be done in expert centres. And even in the UK, which is a very centralised way of delivering care, there's only maybe 2 or 3 centres in the UK that are actively doing, large volume resections, but also publishing their results, So even within HPB centres, the difficulty and the debate is, should all HPB centres be doing this operation? That's the challenge.
I'm glad you brought up a problem. We are reinventing the wheel here, and that is to try and quietly tell our colleagues not to put stents in, because that's a huge problem we face here. Patients with hilar cholangios come in with stents, pre-imaging, and then, like you said, they are lost after that.
But the focus about the stent, just to make one point, and going back to the metal stents, in what we did in Merseyside in Liverpool is to centralise all the stenting in our hospital. And all these cases are discussed at the tumour board before the stent goes in. And the stent is placed accurately by our people. So in terms of the proximal margin on the duct, on the left duct or the right duct, I cut at the top of the stent, and I know I'm beyond the tumour, because that discussion has happened before the scalpel is held in my hands. There is a new technique called the Tesla technique, with the Dutch are trialling, which is using a percutaneous approach to place a metal stent across the stricture, but not across the ampulla. Okay? And it's being trialed in the palliative setting, but it may in the future become the best option in this disease. So that's just something to keep an eye out for.
But that's what we do now, Hassan, that we don't cross the ampulla. We leave the ducts in, because the moment you cross the ampulla, they get into repeated episodes of cholangitis. Yeah. So I think the most important person in this panel is Nilesh. Nilesh, you have to convince your colleagues not to put stents.
I think we do put a lot of pressure on Nilesh. Of course, Nilesh, he works within a surgical. He's in our surgical unit. He's an invaluable team member there, so he knows. But the wider community still requires a little convincing. And one of the challenges is we still don't have tertiary centers where these patients come up and are discussed. But hopefully, in the future, we'll move towards that goal.
Even all units should not be doing hilar cholangio. This is a lifetime commitment. The people who do hilar cholangios will all also not do any other thing, and then others who are doing an occasional metastectomies and all that should not do hilar cholangio. It's a different ball game altogether. It's not even the World Cup; it's a World Cup final. So you have to qualify much before that. So I know that World Cup has a lot of upsets, but this is not an upset.
Thank you.
You think that you've done a left lateral segment, and then, for metastasis, next case is Hilar Cholangio, then gone. When you are, God save you and your patient.
Audience.
One
yes.
center, one center,
Sure.
and one person, one team rather. Yeah.
Thanks. So, audience, we'd like some questions. Any questions you'd like to ask? This one.
I have two questions. One is, if preoperative imaging shows perihilar lymphadenopathy with no history of cholangitis, would you consider that as metastatic disease and not proceed, or will you do a preoperative EUS and take biopsy? And would you consider that as a metastatic disease or regional lymphadenopathy and proceed with resection? That's question number one. Number two is regarding stents. I am opponent for preoperative stenting for operable cholangiocarcinoma. And Mr. Malik said you can put stent. What would you use, covered stent or uncovered stent? Because if you put a covered stent, it will block the ostium of the other side. So an uncovered stent, if you keep it for a longer time, resection will be difficult and difficult to retrieve the stent. Thank you.
Yeah, I agree. Thank you. So basically depends. So you can put on ideally uncovered, but if you're going to stent both sides, you can do it uncovered on both sides. But I completely agree with the ostium, and occasionally we have operated on patients who've got covered stents. And the challenge is not proximally, because you're going to cut beyond the stent. The challenge is distally, taking it out of the distal duct and things. What would be ideal is a different designer stent, which is partially covered and partially uncovered, and that would be quite a nice option for this. But with the Tesla technique, what they're doing is they're putting short stents across the stricture and then taking the PTBD out. So it's a one-stage procedure. So they stent across and it just stays there. In terms of the lymphadenopathy, there's a number of causes for that. I think if there is concerning lymphadenopathy outside the field of resection, so around the celiac axis or elsewhere, then you need tissue diagnosis. If a PET lights up and all those nodes are hot, then clearly they've got advanced disease. But if you're unsure, get an EUS and a biopsy. I think the difficulty is if you've got a patient with node-positive cholangiocarcinoma in whom there's a diagnosis made preoperatively, do we challenge them with systemic treatment? I mean, that's the controversy. That's
KK, you want to make a point? Lymph nodes?
Yeah, can I make?
Yeah, go ahead. Lymph nodes, you can.
Yeah, I mean, two things. The lymph node, EUS and lymph node biopsy is a standard protocol now for those patients who are being considered more and more for liver transplants and who are having subsequently adjuvant therapy and neoadjuvant, and then a consideration for liver transplant, the Mayo protocol. I think when Hassan comes back, probably he will clarify that there was a time when the Leeds team used to go and clear the para-aortic lymph nodes. And as he correctly said, ended up with a lot of complications. But I think going in and taking a para-aortic node for a histology before proceeding with very major resection is a practice in many centers. Because if already there is tumor down there, but then in Hilar, it's unlikely that there should be lymph nodes that far down. So just two comments, because we haven't really discussed about transplant and transplant protocol. So EUS and a nodal biopsy. But if these are paraductal nodes which we clear, then there may be, as Hassan said earlier on, there may be many reasons. If you have had stent, that may be inflammatory, they may be non-specific, so it doesn't negate a resection. Thank you.
I think in the Sri Lankan context, what very often happens is we end up with patients whom we are going to resect or we plan to resect just end up being on an external biliary drain. We found that very often when we try to get stents in, a lot of these patients end up with fairly significant cholangitis. And we quite often that starts off and you go down this vicious cycle of cholangitis, and with time the patients then come to a state where you can't really do anything much. So quite often we've found in our context, EBD is probably a relatively safer option, and then we then go ahead and operate on them. PET scans are still not available. We got I think one, am I right, Prof. Aloka? We've got one center probably we can get them in. So it's few and far between. So, any other questions from the audience?
The Nagoya group has moved away from PTBD because of the recurrences in the parietis. So, but the Japanese do a nasobiliary endoscopic drainage, and we found that to be challenging because our patients, don't want the tubes in the nose. So right now we are pretty happy with PTBD. Possibly one of the reasons is that we don't do too much of brushing along the PTBD tract. The tract implant doesn't happen. So yeah, but node positivity at the gastroparetic ligament is not a contraindication for resection.
Yeah.
But beyond that, as Hassan and KK have said, that then you're chasing something which is not to be done. That's it.
Any other questions from the audience? Okay, I think we've had and I'm happy to say, I think, well, I'm biased, but I was proven right that we'll keep the best for the last. This being the last symposium, the symposium that closes the Sri Lanka Surgical Congress 2022. And I'm immensely thankful and grateful to our resource persons who gave us an excellent insight into this very, very challenging problem that, as HPB surgeons, we know managing this problem that is Hilar cholangiocarcinoma. So on behalf of the Sri Lanka Surgical Congress and the Sri Lanka Hepatopancreaticobiliary Association, my thanks and gratitude to Dr. P Jagannath, Professor K.K. Madhavan, and Mr. Hassan Malik. Thank you very much, and we hope to see you in Sri Lanka probably next year. Thank you very much.
Thank you, Shiva.
Thank you.
Thank you. Thank you. And yes, we'll see you in Sri Lanka next year.
Thank you, Dr. Jagannath. Now, actually, we have come to the end of the SLSC 22 sessions, and we have a few prizes to give before we conclude and start the closing ceremony. I would like to announce the prizes now, and please come to the stage once you hear your name. Essay Edrivira Award for the best paper on trauma goes to Dr. Y.M.K.A. Yapa for her paper on study on demography of neurotrauma related to admissions to a single neurosurgical unit in a tertiary referral center. Next prize, Dr. Bartholomew's prize, Best Oral Presentation, goes to Dr. Hirusha Gunawardana, title, Immediate Outcome of Microwave Ablation for Liver Tumors in a Single Cohort of Patients in Sri Lanka. And Dr. Hirusha, I want you to remain on stage for another prize. You have also got the Best HPV paper prize for your research paper on immediate outcome of microablation for liver tumors in a single cohort of patients in Sri Lanka. The best paper prize, best poster prize goes to Dr. EADLS Udayakumar and the poster presentation titled Low Vitamin D Level and Subclinical Hypocalcemia Leading to Low Prevalence of Hypocalcemic Symptoms and Signs in Patients Undergoing Total Thyroidectomy in Sri Lanka. And this year's best provincial paper and best SARC papers were not awarded. And a special award is going to Dr. P.S. Alas on, that is the special award on from Royal College of Surgeons of Edinburgh, goes to Dr. P.S. Alas, the titled abstract. In brief, psychological intervention is brief psychological intervention effective in reducing psychological distress among cancer patients, a randomized controlled trial in a tertiary care hospital, Sri Lanka.
And in addition to more information, this particular award, the winner, will be freely registered at the next meeting of the Royal College of Surgeons of Edinburgh in Edinburgh, and he or she will get accommodation, everything, but not travel, of course they can't afford, but you'll get full accommodation, full registration and hospitality in Edinburgh. In 10 surgeons, it's excellent.
Okay. I am to announce the Lanka Hospital Raffle Draw winners next. And first Raffle Draw winner, Professor Aloka Patirana.
Suppose Aloka will get a free health package at Lanka Hospital. Who Lanka? Anyone from Lanka Hospital?
Please don't go, there are 4 other winners of the same health package. So the next winner of the raffle draw, Lanka Hospital's health package, Dr. M.N.M. Hiflam. Oh, somebody else can accept the prize if there's a friend of his. Okay. Third raffle draw winner, Dr. Sumedha Bandara. Fourth winner, Dr. Ramendra Senaratna. Malik, can you accept the prize for him, please? Last winner, Dr. Vasantha Vijayanayaka. Anyone from KDU, can you please come and accept the prize? Ranga? Okay, ladies and gentlemen, thank you for that. And I would like to invite our president to conclude the sessions SLSC 2022. Over to you, sir.
I'm not going to hyperventilate or anything, so don't worry. Good afternoon. Once again, we've concluded another surgical congress, SLSC 22. I hope you enjoyed this academic festival, rather informal, where you were able to exchange ideas in different fora, plenary lectures, symposia, meet the expert sessions and master classes of different types. So the whole purpose of this meeting is for you to gain knowledge, skills, and exchange ideas. And final, we'll be very happy if you can translate it to your action. When you are practicing, working with patients, to use the knowledge and use it. And we thought this year to have a higher level thinking being inculcated you rather than didactic teaching of points to, look at things from a very higher analytical level, because not only for exams, when you trainees, when you practice, even our colleagues who are fellow surgeons, I'm sure, would have got that idea. Well, it's not for me to decide whether this Congress was a success or not. It's up to the people who, all of you who attended the Congress, to decide, because I don't want to exalt myself or anything. But I want to thank all the members of the organizing committee, my secretary, our secretary, Kavinda Rajapaksha, Gayane Kanayaka, Amila Jayasekara, and the two academic chairs who played a very pivotal role in organizing. They all don't want to show themselves up, very simple human beings. And naturally, there are two urologists, Ajit Malalasekara and Ranga Vikramarachi. Let us thank them in the usual fashion for organizing this Congress. And also I'd like to thank our office staff, Mr. Dayananda, Chatusha, and Amali, for their dedicated work, and Hirun. They were silent workers, once again working till late in the night, sleepless nights. So this is the fruition of this collective effort, not only one single person. And I am just a symbol. I hold position in trust for your benefit. I'm not a command or anyone. I'm a simple surgeon holding position in trust for you all. So, and thank you so much. Please be compassionate when you go to work. I'm sure all of you are compassionate. Be compassionate to patients, compassionate to your team, compassionate to all. And just have your human core values. Then I'll be the happiest person over here. And you will see, when you are a compassionate leader, outcomes will be super, patients will be happy, the teams will be happy, and they'll be working harder and harder. So with much ado, I'll conclude this annual sessions. Hope next year there'll be annual sessions as well. So you'll be notified of the dates in near future. Please watch for the updates on your app and also in the college websites. So Professor Nandadeva Samarasekara will be taking over the presidency from January. So you'll be updated on all the details. And have a pleasant evening and a nice weekend, and enjoy. Thanks a lot.